Welcome to Podcast UK.
Hi there, I'm Sanjib Majumder. I'm a plastic surgery consultant from the United Kingdom, and I thought that for today's shorter cappuccino break episode on Podplast UK, we discuss dual plane augmentation. Now, the concept of dual plane augmentation, as developed by Dr. Tebbit, was a game changer in breast augmentation technique. But in my experience, many trainees still struggle with what dual plane breast augmentation actually is, what constitutes the three types of dual plane augmentation, and how dual plane augmentation differs from subpectoral augmentation. In dual plane breast augmentation, the implant is situated so that it lies in two pocket planes, thus the term dual plane. The superior part of the implant lies directly behind, that is to say deep to, the pectoralis major muscle, and a variable amount of the inferior part lies directly behind the breast tissue of the inferior pole of the breast. Using this technique, the surgeon can more effectively control how much of the implant lies behind the muscle and how much lies directly behind the breast tissue itself. To paraphrase Dr. Tebbit, dual plane breast augmentation allows the surgeon to offer augmentation with improved cosmetic outcomes, bespoke to the wide range of breast types, optimizing implant soft tissue dynamics, thus increasing the benefits and decreasing the trade-offs. Now, this is how it's done. The chest wall can be approached using the popular intramammary fold skin incision, or some surgeons may prefer the periareolar or axillary approaches. Then, to access and develop the subpectoral pocket, the origins of the pectoralis major along the intramammary fold are divided completely. The complete division of the fibers of the inferior region of the pectoralis major is different to the manner in which the same space is accessed when performing a subpectoral augmentation, where the inferior region of the pectoralis major muscle is usually either not divided or divided only partially. So that's an important distinction between dual plane breast augmentation and subpectoral augmentation, because this complete division of the inferior origin of the pectoralis major allows the muscle to retract superiorly to some extent, like a roller blind, altering the position of the pec major muscle relative to the implant, so that some of the inferior part of the breast implant lies immediately behind the breast tissue. However, the extent of the superior retraction of the muscle is limited by the attachments of the breast parenchyma to the anterior surface of the pectoralis major muscle, the so-called breast parenchyma muscle interface, and also by the remaining muscle origin attachments along the sternum. It is very important to stress that the muscle attachments along the sternum must not be divided, as this can lead to cosmetic disasters such as visible deformities from the cut edge of the muscle adhering to the overlying skin and subcutaneous tissue, the edge of the implant being visible, visible traction rippling, or even synmastia. However, dependent on the specific aesthetic requirements, and these are outlined in detail in Dr. Tebbit's paper, the surgeon can release the parenchyma muscle interface to varying extents, thus allowing further retraction of the pectoralis muscle superiorly and determining the proportion of the implant that lies directly behind the breast tissue. Now, there are three types of dual plane breast augmentation described by Dr. Tebbit. Type 1 involves releasing the origin fibers of the pec major muscle completely along the inframammary fold, but no separation of the breast parenchyma muscle interface is performed, allowing a degree of retraction of the pec major muscle superiorly with a small amount of the implant lying directly behind the breast tissue of the inferior pole of the breast. Again, to emphasize, the origin fibers from the sternum must not be divided. The type 2 procedure, in addition to the aforementioned division of the pec major along the inframammary fold, the breast parenchyma muscle interface is separated up to the inferior edge of the areola, allowing for further superior retraction of the muscle than in type 1, and with a larger amount of the implant now lying directly behind the breast tissue of the inferior pole of the breast than in type 1. In type 3, the procedure is as in type 2, but the breast parenchyma muscle interface is separated even further, up to approximately the superior edge of the areola, allowing for even further retraction of the muscle than in type 2, and an even larger amount of the implant lying directly behind the breast tissue of the inferior pole of the breast. In his paper, Dr. Tebbit recommends that type 1 dual plane augmentation is suitable for most routine breasts. Type 2 is suitable for breasts with highly mobile parenchyma, and type 3 augmentation is suitable for glandular breasts, ptotic breasts, and breasts with constricted lower poles. Dr. Tebbit includes a very detailed discussion expanding on the indications for each of these three types of dual plane augmentations. This discussion, however, is out with the remit of this podcast, and I would strongly recommend that the listener read Dr. Tebbit's paper titled Dual Plane Breast Augmentation, Optimizing Implant Soft Tissue Relationship in a Wide Range of Breasts. This was published in the April 2001 issue of the journal Plastic and Reconstructive Surgery, PRS. I hope this podcast has helped clarify the concept of dual plane augmentation. However, if you're more of a visual learner, I have discussed the concept of dual plane augmentation with illustrations on my YouTube channel, Medicine in a Nutshell. Good luck and thank you for listening.
Podplast UK is a collaboration between UK and Irish plastic surgery trainees and consultants. The content reflects individuals' practice and opinions may vary. If you have any feedback, do get in touch. We hope that this has been interesting and useful. If it has, remember to follow us for future sessions.